I wanted to really talk about something that's very relevant to all of us these days, which is video consultations and examination of the hip and knee. Now, we all know that there's no substitute for seeing a patient face-to-face, and some patients prefer that. The trust, the connectivity, confidence, they just feel they can only explain themselves sometimes in that format. But for those who prefer to have the convenience of a video consultation, I found that there are certain techniques that can be really useful to get more information. And it's a matter of being, I'm sure you've found that it's you have to be a little bit creative and accommodate what the patient is able to do, what they feel comfortable with. It's quite different from the standard consultation. I think quite often with hip and knee, there's the very genuine recognition that it's a mechanical issue most often. And so just speaking to the patient and being in many ways a passive observer of what they're expressing is sometimes it's tricky to see how you're going to get the right information. And so I'm hoping that this session will be quite useful for that. When it comes to having an early and convenient consultation with the patient, of course, the goal is diagnosis and driving forwards in terms of managing the problem. And it's hugely reassuring for patients to hear that there's an explanation for their problem, and hugely reassuring to hear that very often the treatment is straightforward, whether it's surgical or some other modality. Treatment for really every condition affecting the hip and knee is very well established. And every year I see a few, it's very rare, but every year I see a few patients who have a very serious problem. I'm talking about a tumor, avascular necrosis, and very often the patients don't present with the classic red flags of night pain and constant pain and weight loss. Very often they just have hip pain or knee pain. And so the consultation and investigating their problem is obviously really key in getting them prompt treatment. But that is rare, of course. And so for the majority of patients, it just allows them to move forwards. Now, we're very lucky today to be joined by Daniel, who is, he is assisting us as the patient model. And I'm going to ask Daniel just to stand for me in front of the chair and look at the camera. If you turn around, turn around completely and look at the camera. So if you ask the patient, where does it hurt? And they will point to the side of their hip, perhaps. And obviously the way that they point and how they do it is very dependent exactly on how they want to do it. You have no direction over that. And so it's a little bit going with the flow. And thank you, you can relax. And so pain at the side of the hip is nearly always quite benign in nature, very often reflective of trochanteric bursitis with very well-established and predictable treatment. Pain at the front of the hip, so if they point to the front of the hip, particularly if they do this with their hand, the C sign is very typical for labral pathology. And pain arising from the hip joint itself typically will be felt in the groin. And that's a non-specific sign, but using the patient's ability to point to their own body is obviously really important when it comes to localization of pain, localization of neurological symptoms such as neurological pain and numbness. And so the first thing I do is really ask those questions. The second thing, which is really very broad at picking up pathology, is gait. And so, Daniel, I'm going to ask you to come back over here for me. Thank you. And can you walk to the door for me, please? And we can see Daniel has the thank you, and please turn and walk back again. He has the easy reciprocating gait, but the thank you, and walk back to the door, please. It's amazing how often patients haven't even noticed that they're limping. And sometimes thank you very much. Sometimes a really obvious diagnosis. So I saw a patient back in February who it was her first presentation. She came with hip pain, but it was actually her first presentation of multiple sclerosis. Very unusual for an orthopaedic clinic. but it was her stiff, hypertonic gait that really was pointing towards a neurological problem as the thing we had to chase down. So gait, that is extremely useful. And as part of gait, you may see a Trendelenburg gait. And examining for the Trendelenburg sign is also really straightforward in the physio consultation. Daniel, if I can ask you to stand, put your hands on the chair, face the chair, and put your hands on the chair, please. Great. And then I'm just going to ask you, stand with one leg straight and bend the other knee. Great. And put the leg down. And stand on the other leg and bend the other knee. And put the leg down. And you can see that the pelvis doesn't droop. You can see that the pelvis on the unsupported side rises very slightly, which is normal. But if you stand on one leg, bend the other knee, great, and the pelvis droops on the unsupported side with the patient lurching to the other side, thank you, and stand straight, that is a Trendelenburg positive sign indicative of abductor weakness and hip pathology. So that's something we see not that often, but it is extremely useful because it's universally an indicator of a serious problem. Okay, Daniel, I'm going to ask you to turn the chair around for me now. And we're going to have a look now at hip range of motion. If you can sit for me on the chair, that's brilliant. And one thing that's really quite difficult to do when we're doing a video consultation is to examine a patient's range of motion, because we're used to having two hands on the patient, guiding their movements. Examination of passive range of motion always comes first. But this is a good trick. I call it the Charleston dance test. So Daniel, if you can put your hands on the chair, please, and keep your knees facing forwards, and just bring your one foot out to the side as much as you can. Okay, and relax. And you can see Daniel's twisting slightly in the chair, and this is quite typical of video consultations. The patients will do things slightly differently, and it's difficult to guide them, and patience and just going with what they do is really key. So Daniel, can I ask you to sit back in the chair for me? Shuffle all the way back and keep your knees facing the front and sit straight. And now just bring your foot out to the side. Great. And bring it back to the front. And now can you do it with both feet out to the side? Okay, great. And back to the front. And so you can examine for the range of motion of internal rotation. And loss of internal rotation, as we know, is the earliest sign of hip arthritis. And so this really useful finding can be replicated even when you're not in the room. And you can look at the range of internal rotation and the symmetry of internal rotation, both sides. Okay, great. If I can ask you to stand up, Daniel. Another useful thing is to go on tiptoe. Great. And stand on your heels. Okay, great. And so that's a really good sign, and stand straight. That's a really good sign of if there is nerve pathology. So hip and spinal pain are often confused. Pain in the buttock very frequently is sciatica, but it can be arising from hip arthritis. And sciatica with pain radiating down to the foot, into the foot, neurological signs. It's not always that clear cut, and pain radiating to the knee can be coming from hip arthritis. So it's quite rewarding to be able to differentiate the two with a video consultation. Okay, Daniel, if I can ask you now to lie down on the couch for me. And this is an ordinary sofa, just as a patient would have at home, not an examination couch, but it's surprising you can get quite a lot of information in this way. So Daniel, I'm going to ask you to actually shuffle to the edge of the couch for me. Not right to the edge, but just more to the edge so I can see you really clearly. Yeah, a little bit more for me. Great. And now with your left leg, if you can bend the knee for me and hold the front of the leg and bring the knee into the chest. Great. And you can see Daniel's left leg is also, his right leg, his right knee is also bending slightly. And relax for me. And so this replicates Thomas's test for fixed flexion deformity of the hip. And in a patient who is able to bring their knee all the way into the chest, and able to push the other leg down, you can have some confidence that both hips are quite supple. Even though the couch is soft, even though a lot of spinal movement will accommodate some stiffness of the hip, the most useful thing is if they're not able to push the leg down, that indicates significant pathology. And so you can look at range of motion quite effectively in terms of the most useful measures, which are fixed flexion deformity, flexion range, and internal rotation of the hip. Now we're going to have a look at the Faber test, which is actually quite difficult to explain. So Daniel, if I can ask you to bend up your left knee and put your foot across your knee, other knee, that's it. And now just take your hand and push down on your knee. Great, and relax. And so this test, flexion, abduction, external rotation, will tend to stress the sacroiliac joint. And Paul and I are both also pelvic trauma surgeons. And so we can investigate patients with sacroiliac joint pathology, and very rarely they require a sacroiliac joint fusion. And so one of the first indicators is the pain around the hip actually localized to the sacroiliac joint, and so that's useful. Now, if this test actually gives patients pain in the front of the hip, that's more likely to be an indicator of labral pathology. And labral pathology is notoriously difficult to diagnose. Thank you, Daniel. If you can come and have a seat over on the chest. With labral pathology, examining the patient face to face and putting the patient into extreme positions to stress the labrum is really key. And that's quite difficult to replicate in a video consultation. And in terms of making a diagnosis, the imaging, MRI or MR arthrogram, are notoriously unreliable with very high false positive and false negative rates. So I suppose that's one area where seeing the patient face to face is really useful. So Armin, there's no particular questions or comments at the moment? I just want to check.
There is one that's come through. It's more of a case, but I'll just read it out to you. So one of our GPs had a patient with pain in the lower back and wobbly on feet. Prostatic CA, weak dorsiflexion on foot on video, referred to neuro. What's your thoughts?
Yes, exactly the right thing to do. I think you lose some of the subtle cues that you pick up with face-to-face are much more difficult on video consultation. And so there are some really clear pointers there that this could be, it could be spinal cord compression. Especially if the patient has a hypertonic gait. And so a rapid referral so the patient can be investigated and treated appropriately. Firstly, it's very reassuring for the patient if actually there isn't anything serious. And secondly, obviously, if there is, they can have prompt treatment. So I completely agree I would do exactly the same in that situation. So thought we'd go on to talking about Paul is going to talk about knee cases and knee diagnoses, but I thought I would just share some tips for knee examination in the video consultation. Yeah, shall we move to that? So Daniel, we get Daniel back again now, and Daniel's going to walk again to the corner of the room, and he's going to walk to the door, and you can see that he's not limping, and come back and walk this way. Great. And then one thing we try and do sometimes is get the patient to squat down on one leg. And Daniel is pretty strong. And so he's not bad at it. If you stand up again, please. But actually you can see that a lot of things get in the way of that, including your core strength, your balance. It's quite a non-specific sign. So Daniel, if I can get you to go back to the door now. If you walk back towards the door, and turn and face us. Okay, and if you just stand a little bit forwards, come forwards a little bit, that's it, stand there. And if you can squat down for us all the way, just squat down, great, and stand up again. So it's pretty rare that a patient with meniscal pathology is able to do that. So that is a really good screening test. And then walking in a squat position, duck walking also. If you squat down, yeah, and keep your back straight as you can for me. Great, and walk. Fantastic, and relax. You can sit on the chair for a minute. And so, again, a patient with meniscal pathology, is really unlikely that they're able to do that. They'll get pain at the level of the joint line. And again, asking the patient to put a finger on exactly where the pain is, it's surprising you can localize with their pointing, sometimes the medial femoral condyle, the meniscus, the patellar tendon. You can localize things really quite accurately with patients telling you exactly where the pain is. It's not a substitute for palpation, but it does give you some idea. And then, Daniel, if I can ask you to turn the chair around again, there's another quite fun test that I find patients can often cooperate with when it comes to looking for knee pathology. Just move the chair back a little bit. Thank you very much. And so now stand in front of the chair and put your 2 hands on the chair. Great. And I can ask you to stand on one leg and bend the knee very slightly. That's it. And now twist from side to side. And this is the disco dance test, loading the medial and lateral compartments of the knee. Thank you very much. And stand still. And you can do that to check again. It's most sensitive for meniscal pathology, but obviously a patient with significant arthritis will find this very painful. And of course, it's really important to be sensitive to the patient's comfort and not to do anything that provokes pain further than is really necessary. And now if I can get you to lie down on the couch again, Daniel, I'm going to show you one other really important sign. In the acutely injured knee, there are really obvious signs. And just shuffle to the edge again for me. Thank you very much. There are really obvious signs of pain and swelling and sometimes instability. But one thing, sometimes when the pain and swelling has settled down, that becomes obvious in patients who present a few weeks after the injury is a locked knee. And so Daniel is going to just demonstrate the locked knee. Daniel, if I can ask you to bend the knee very slightly, less than that. It's often just a little bit bent. And you ask them to push down, push the knee straight. He's pushing and he just can't. So that is a locked knee. That requires an urgent arthroscopy to unlock the knee and to restore the patient's function. Okay, brilliant. Daniel, if I can ask you to come and have a seat on the couch for me. Sorry, on the chest here. So are there any particular questions or comments about those tips? Has anyone found that perhaps there are other tips that are quite useful? Sometimes patients want to demonstrate a certain maneuver that causes pain. I'm always interested in seeing that. And the information you get is often more guided by the patient than it is in the face-to-face consultation. But there's always useful information in terms of what the patient wants to tell you and what you can elicit from the patient as well. Armin, are there any more comments, do you think?
Yes, we've had 2 come through. So I'll read the first one. Any tips on examining ligaments of the knee remotely?
Yes. So it's a very good question. So the first thing I would say is in the acutely injured knee, so this is the patient with a high energy injury, football, skiing, rugby, these types of mechanism of injury, they present very painful, usually very swollen and bruised, and they typically have a sensation that the knee feels unstable. And that's more unusual in an isolated ligament injury. That's more common in a very serious multi-ligament injury. If the patient says, my knee feels unstable, that's a really big warning sign the patient needs immediate attention from an orthopaedic surgeon. And having a multi-ligament injury is really dangerous in terms of the potential for further injury to the blood vessels and nerves and a limb-threatening situation. So that is an emergency situation. If your patient says, my knee feels unstable after a high-energy injury, that's quite alarming. In terms of an anterior cruciate ligament rupture and getting information about that, that is tricky in the acute stages. All you will generally see is a patient who is in pain, is reluctant to move the knee. There's a lot of bruising and swelling, usually. What I find really useful is in a delayed presentation, sometimes the patient will say, my knee was very swollen, but now 2 weeks later, the swelling is gone. And you can ask them to, very often they remember very clearly where the swelling was, and you can ask them to point to where the swelling was, and they will very clearly indicate the suprapatellar pouch, just above the patella. And that is a real giveaway that there was an intra-articular effusion, a large one, very often associated with a significant injury to the knee, very often anterior cruciate ligament rupture. I'm going to ask Daniel to demonstrate one more test for me. He's been excellent and very patient with me. If I can ask you to lie down on the couch, Daniel. Great, and just shuffle to the end again. And just bend your, great, and shuffle to the edge this way as well. And just bend your left knee for me. Okay, a little less than that. Great. And just the thigh muscle, the muscle on the front of your thigh, not the side of your thigh, that's it. Just tighten it for me and relax. And tighten it and relax. So this is the quadriceps active test. And it's one of the few tests that you can do quite easily on the patient without laying hands on them. And this is a test for posterior cruciate ligament rupture. And in this test, the knee, so when you look at the knee from the side, the tibia sags backwards. It sags behind the femoral condyles, and compared to the other side where the tibia, the anterior line of the tibia comes in front of the tibial condyles, the injured side, it will sag back. So that's the first thing you see, posterior sag side. Then with the quadriceps active test, the patient contracts the muscle and the tibia moves forward. It's quite a striking test if you see it, but it is rare to see an isolated posterior cruciate ligament injury. Those are not very common. So those are my tips for examining the ligaments around the knee remotely. Any other questions from anyone, Armin?
Yes, we do have one more. So this GP is happy to do video consultations, but by the time they arrange it and do the test, it takes more than 15 minutes, sometimes 25. Do you have any tips on how to cut these times down?
Yeah, so I have to say, I find that my practice is to give the patients as much time as they need. And it does mean overrunning sometimes, but I just think what I would gain in terms of efficiency, I would lose in terms of the patient's confidence. And so I tend to just give them as much time as they need. And sometimes with a complex patient or a patient who has many problems, that can be really tricky. I suppose the one thing I would say is that there are some patients who want to talk about other things, and there isn't really a lot of time for that. We have a bit of chat for a couple of minutes, but after that, it's really important to focus on what's important. And so really useful phrases I find are, let us talk about your knee. Your knee is the important matter here. We need to focus on that now. And you can remind patients of time as well. You can say, we have just another 5 minutes, so I really need you to show me what is going to be helpful, and then explain the test. And so one thing that I've heard colleagues do sometimes, just to demonstrate on themselves, they will put their own video cam directed to themselves and stand up to demonstrate what they want to do in terms of bending the knee. I have to say I haven't had to resort to that. I find patients, if you're patient with them and allow them to do it in a way they feel is comfortable, it does take a little longer, but they usually get there just by directing them verbally. So I guess another tip is to practice those phrases. Can you bend the knee? Can you take the knee into the chest, put your hands on the front of the leg, so you can direct them really clearly, and just be patient. That would be my tip.